I'm here.
Okay, so Fanny, as soon as 5 seconds after I hit record, you can start, okay?
Okay, thank you. Welcome and thank you for joining us today for the meeting of the New York City Health and Hospital Strategic Planning Committee. Today's meeting is officially called to order. I would like first to propose a motion to adopt the minutes of the Strategic Planning Committee meeting held on November 5th, 2020. Anybody second?
Second, Jose
Second.
Paez.
Thank you. Does any member has any questions concerning the minutes?
No.
No.
So,
Nope.
I will poll every member. Jose,
Yes.
Dr. Katz,
Yes.
Sally,
Yes.
Frida.
Yes.
Okay. Anyone opposed? No. The meetings are adopted. Now we will turn over to Mr. Ziegler. Matt.
Yes, sir. Thank you, Mr. Chair. Good to be with you all. Happy New Year. Time of optimism and new challenges every early January. So good to be with you. We are reporting today on Q1 of fiscal year 2021. So we'll update you on some of our metrics there. The time period that covers, as folks know, is July 1 through September 30th. So really our, I'd say, kind of reopening phase after the spring COVID surge, and the numbers reflect that. The declining patient volumes that we saw coming out of the surge, again, continue to impact some of these measures, but we'll show you a good report and some very positive trends. We have updated 2021 targets and priority measures that reflect our discussion in last quarter's meeting. And we'll take you through some of the important results here. We also have some discussion of future changes to the metrics, particularly on tracking some of our vaccine rollout, reorganizing some of our IT measures under some of the other categories, and then beginning to incorporate social and racial equity, our foundational goals, into some of the key KPIs that we will report to the board. So we can talk more about how we will reflect that in future meetings, but today we'll take you through these our positive, negative, and then stable trending measures, and spend a good amount of the time at the outset talking around what we worry about most, or focus on to some degree from a strategic perspective, the external factors that are affecting our performance. We're doing a great job on the internal levers that we can control, driving real operational improvement, but watching those external factors will have a big impact on what our year looks like. So with that, Deb Brown has joined us today, I believe. I don't see her name on the screen. Not here yet? Oh, okay. Well, Deb is going to join us, and if she doesn't, I will do my Deb impression. What we wanted to talk through today is some of the key external factors, federal, state, and city, that we are watching and thinking about for our FY21 performance and going into 22 for the system. The diagram on the right you'll recognize from our last discussion, the key strategic processes and inputs that feed up to what we present here to the board and discuss at Dr. Katz's leadership team. And one of the key partners, is external and regulatory affairs. Deb leads our community health needs assessment work along with some of my colleagues at One City. She convenes our quarterly stakeholder meetings with community groups and other advocates who are interested in joining us for discussions about the future of health and hospitals. And then she meets very regularly with our community advisory board. So it's a good and important broad range of input for the direction of the system. In addition to that, she and her team are frequently in touch with staff, leadership, elected officials at the city, state, and federal level. So for a small and mighty team, they get a tremendous amount of input and have a lot of influence at these different levels of government. So that is important. I guess I will start the discussion, maybe starting with the federal side, because that is where I spent the early part of my career and still have some friends and familiarity down there. Clearly, the change in administration and the change in control of the Senate is a positive development for the finances of New York State and New York City, and by extension, health and hospitals. There is still significant implementation work to be done on existing federal relief packages. The most recent package did not include the highest priority for, I believe, the mayor and the governor, which was state and local relief. You will see throughout this discussion that that decision kind of cascades and affects a lot of the decision making here. That's a gap that we hope the Biden administration will fill. There are also key elements of how FEMA funds are getting distributed, how provider relief funds can be backfilled or offset with FEMA funds, some key decisions around the implementation of prior relief packages, in addition to how those relief packages are targeted towards safety net providers like health and hospitals, that we still do want clarity on, and we want favorable decisions that will give us more resources to support our patients. So those are critical. And the Biden administration will have things to say about them, and we will be in touch with them. We have friends and colleagues and contacts in that administration, including some former health and hospital staff who have moved down there to take part in that effort. So that should be hopefully a productive relationship. Other priorities for the incoming administration around on the health side. Clearly, vaccine delivery and distribution is a very high priority for theirs. They've established a very strong team, including some of the key people who saved healthcare.gov during the initial launch or challenged launch in 2013, 2014, brought in a good mix of former White House officials, former HHS officials, and operational leaders from health systems around the country. So that vaccine rollout will be critical of theirs, and I think you've already seen some of the changing strategy and prioritization announced in terms of how quickly they will release inventory, how transparent they will be about it, and what their plans are there. Beyond that, they have clearly signaled, and there's been a lot of discussion throughout the campaign and the transition about the interest in expanding health access and improving health equity around the country. COVID is a key vehicle to do that, and a key way they look at that. But I think their broader agenda around health insurance coverage and expanding and improving upon the Affordable Care Act will also be key to what they do. That is my knowledge, and I will hand it over to Deb or take questions from you whenever that works.
Hi there. Sorry about that. I was having some technical difficulties. Happy to take questions.
So I think that's an overview of the federal side. Are there questions on the federal priorities and where that work is?
Yes,
for our
I have
system?
I have a quick question. Are you able to hear me, Matt?
Yes, I am. Hi,
Unmuted?
Sally.
Oh, great. Okay. So, we praise God, we have a new government, and one that's more sensitive to healthcare equity and generally, but it's still a government with significant budget gaps. And they have been working on setting their priorities. Clearly, the vaccination is number one. I'm just wondering, in terms of budgetary relief, both implementing what's been promised and considering additional items which they haven't been looking at as seriously, perhaps. Is that also being considered a priority, or is that just not up for discussion yet?
I'm happy to jump in here, unless Matt, you wanted to start. I think, Sally, it's a really astute question. I think you certainly hear conversations and expressions of support from the Biden administration and others in terms of understanding the needs for ongoing financial support for healthcare providers, as well as for individuals, small businesses, et cetera. I do share your concerns in terms of, blood from a stone at some point. but they are still saying the right things and still acknowledging all the work that we do. And, one of the things that we have been trying to do is really tee up ongoing support, certainly on, what you'd call more of the expense side, but also on the capital side, on the infrastructure side, because so much of our work continues to be based in the need for our resilient buildings and our resilient facilities.
Okay, thank you, Deb.
I will go over if there is anybody that has any questions. Jose, do you have any questions?
No, thank you. Thank you for the update.
Frida?
That was really helpful, and yes, hopeful for change. And one question that and Matt, you might have mentioned this, I just didn't hear. On the dish cuts, where do those stand right now?
So dish cuts are delayed essentially until fiscal year 2024.
Okay.
So we are in good shape on that, continues to be good bipartisan support.
Okay. Because I thought that weren't they going to come?
They're always, yes. Yeah. This is
but now
sort
we
of
have a long extension to 2024 is what you're saying.
Yes.
Okay. And maybe now some changes given what's happening.
Maybe so. I mean, I think it's a matter now that the folks coming into office are the folks who really created the Affordable Care Act and sort of understood the concept of the development of the dish cuts at the time, and now can see how it doesn't actually match reality. I'm hopeful from a policy perspective. Financially is another issue.
Okay. And then on the infrastructure side, I know in my world, we're talking a lot about potential for infrastructure bills and what might be going in there. It sounds like that's an active part of our policy agenda with the government as well. Is that? It
is. And, I've said this to a few of you, in addition to kind of the sort of conventional infrastructure bills, there are some things floating around about healthcare planning, public health force planning, and we have been able thus far to insert some infrastructure language into kind of the key one of those. So, don't count your chickens until they're hatched, but things are, I hope, moving in the right direction. And I think a very big component of what we're going to be doing on the federal work with the new administration is also ensuring support, continuing to ensure that we get what we need from FEMA.
FEMA, right. Okay, great. Deb, at some point, I'd love to talk to you a little bit about that on the infrastructure side, because it's
of course
from what we typically are seeing on the infrastructure front. So
interesting. Yeah, I'd be curious for your take from that side of the world.
Thanks. Thank you, Fanny.
Thank you, Frida. I don't know if Dr. Katz had any questions? No. Deb, I have a question. I know that you have elaborated on this before, but we are looking at a situation in which the Senate possibly will have a majority leader that seems to be very open to listening and really caring about the type of work that we do in the system. Is there anything that you could share on how we are approaching the situation on the landscape changes in leadership in the federal government that will support our goals?
For sure. And first of all, thank you for the question. I also want to underscore, what Leader Schumer has done. I like saying that. What Leader Schumer has done for hospitals and for New York hospitals is historic and significant. He has, certainly as long as I've been in this business and far before that, really been a stalwart supporter of hospitals, really understand the role we play, and also really understand the role we play in terms of training workforce. He's been very focused on GME previously. So we're, it kind of couldn't be better for lots of reasons to have a real New Yorker and to have someone who cares so deeply about hospitals. So that's a really wonderful thing. Dr. Katz doesn't know this, but I am in the midst of drafting a welcome letter laying out all of our priorities and seeking time. So Dr. Katz, that is coming to your desk shortly. And what's nice as well is that certainly, we've had relationships with his office, continue to have relationships with Senator Gillibrand's office. And on the delegation side, In terms of the House members, there are some members that continue to be in leadership positions, and we've been able to create relationships with them over the years. So, fingers crossed. I hope we will be in a good position.
And Deb, I know that during the crisis, the height of the there were several members of Congress that visit us. Was the leader Schumer one of those, or no?
No, that tended to be more on the House side because naturally, and I'm thinking of Representative Meng, for example, who's so extremely supportive of Queens and Elmhurst Hospital. People who sort of have that neighborhood connection, which is not to suggest that the senators don't care deeply, but I think on the House side, the facilities that are in their districts are really where their hearts are.
Okay.
And we got really a wonderful outpouring of support, a lot of, how can we help you kind of questions, especially during the first surge, for which we were grateful.
Thank you. I guess there are no more questions.
I just have a quick question.
Sorry, Sally.
The new Attorney General has made healthcare equity one of his priorities. So I guess we'll be reaching Health and Hospitals, HHS cabinet member has said he makes health equity a priority of his. And I guess in terms of just even regulatory relief and things that we might need, that's a positive for us.
Yes, and just for awareness, there was an opportunity recently in RFI at the federal government, as well as opportunities to communicate with the transition team, identifying our request for regulatory relief. I mean, so much of what has happened in this surge, we've been able to take really necessary critical actions because of relief afforded both on the federal side and on the state side. And so we have, continued to do advocacy throughout to maintain those relief, certainly during COVID, but for many of them thereafter, because this is, such an important kind of natural experiment to show how we can continue to provide care safely, effectively, with high quality, with equity, without a lot of the regulatory barriers.
Thank you. I think we can continue. Matt or Eric, I don't know if you're planning to continue the presentation.
Sure. Well, we gave our federal overview. I mean, Deb, I think it flows from there it remains an open question of whether federal and whether state and local relief will be included in a direct package, but certainly a supportive environment that then trickles down to the state and city.
Absolutely.
Deb will get.
No, that's exactly right, Matt. And so much of what we need on the state level and on the local level is tied to that necessary funding, which of course was left out of the most recent package, with the understanding that with a Biden administration, folks would go back for another bite at that apple. And so, we are seeing in the state budget process start to take place today. Just now is the state of the state. So, part of why I was tardy, I apologize for that. In the rollout to that, very interestingly, one of the things that the governor has highlighted is his support for telehealth flexibilities. And that's something that's probably been our ongoing number one state regulatory priority. So there's a, press release and sort of a big announcement that came out. We're waiting for actual language, but that is something that I think is really great for healthcare delivery, and also really great for us at H&H financially. We're all of the sort of parity and coverage and payment requirements to come through. So we'll be looking at that package. Of course, the state is, addressing a significant budget gap. So as the budget process starts, which will be in the next few weeks, the concern, of course, is Medicaid cuts, is across the board cuts, have been threatened previously. We are continuing our advocacy. During the last couple of months, we've been doing outreach meetings to sort of the relevant stakeholders on the state side, both the legislators and the committee staff. And we are, moving into gear in terms of working with our community advisory boards for advocacy. That is coming up shortly. It'll be a weird year. Usually Michelle DeBacco from my team, does such a masterful job of literally rounding in Albany. So it'll be, she's doing a lot of her work, and we're all doing a lot of our work in new ways remotely.
Great. Well, thanks, Deb. With the board's, we'll move into our performance updates. As I said, the general period is our kind of reopening period. It was so you'll see a lot of positive trending metrics, which we're very proud of. Moving up from the very, very difficult period of the surge, we opened up, and I'd say opened up better and stronger than many would have expected. So that's great. Our e-consults were up to almost 66,000 from the prior quarter. That's a great result in our kind of key measure of how quickly we can get people specialty and subspecialty access. So very pleased to see that continuing to progress around the system, and will be a key part of our telehealth strategy going forward. NYC Care is citywide, as folks know, as of the end of the fall of 2020. So we're at over 35,000 enrolled in that program around the city, which is terrific. Two of our key kind of global measures of revenue and financial health, our patient care revenue over expenses, it was at 65%, up from 61. I think that's very strong and a result of good revenue and maintaining expense control even after the surge period. And then the percentage of Metro Plus's spend at health and hospitals versus other facilities was up to over 42%. We may see these dip off as the revenue begins to move to other facilities, and things return back to normal in the next quarter that we report on, but very positive trends nonetheless. And then operationally, seeing our AR days per month start to drop again shows that folks were tracking well on the billing side and getting those out the door at a faster clip post-surge. So very positive and good to see. The next page shows a few more positive ones. Our MyChart activations continuing to force us to come up with new stretch goals. Kim and the team and others are doing so well on this. We are over 50% as of this month, but as of September 30th, we were at 36%, which is terrific. It's just to show you the benefit of it. It is making outreach to get our patients, now that we are in 1B, getting patients enrolled and ready for a vaccine appointment, making it much faster to have this big built up inventory of folks who are connected to our system. We can easily push an appointment to, and they can quickly get in, all digitally scanning and get in and get their vaccine. So it has real world benefits. It is the quintessentially valuable IT measure, not just a measure of technology, but of kind of real patient experience. So that's terrific. Our post-acute measures, this is a new measure as of Q1. This is the hospitalization rate, dropped to 1.32, so that is strong versus the prior quarter. We had a slight uptick in the follow-up appointments kept after behavioral health discharge. This has been a very challenging measure and is a real focus of our behavioral health clinical teams. So that's very positive to see it trending in that direction. And our percent left without being seen in the EDs continues to remain very low. Again, I think this is both a measure of the hard and good work that Eric and the ED leadership around the system have done, but clearly a reflection of a very low, for us, emergency department volume over these summer months. It did tick up a little bit towards the end, but the EDs were quieter than they have been. And thankfully, even during this winter surge of COVID cases, the emergency departments have remained very stable, which is great to see. Eric, if you're on, do you want to speak to care experience?
Sure. I think, right, this is something that we're very proud of, that our inpatient care and ambulatory care metrics actually went up even in the spring and continued through the summer. I think it shows, the type of mission-driven people that work for health and hospitals, that even during a pandemic, they're making sure that they're treating the patients and their families as they would their own. And so, I think this was something that I was afraid we would take a hit on, but very good that it was actually the opposite, that we actually saw some record highs in some of these gaining scores.
Great, thank you. Our negative trends on the next page, I think the first one, this is a rolling 12-month number that tracks the number of unique primary care patients we've seen. So the prior quarter was a very positive one, but this I'd say dropped because it reflects now 6 months of the surge and post-surge period in that 12-month average. So clearly new primary care patient volume did drop off a good amount during the COVID surge and in the months after. We spent a lot of time and effort trying to begin to grow volume in the immediate post-surge period, but we still were down as a percentage of visits that we were seeing. The next is a new measure, but an important one that we'll track the trending of. We show you here negative because of where it's trending against target. This is the percent of uninsured patients who come through our doors and who are then enrolled in either health insurance coverage or in NYC care. So that's at 61%. Ideally, you'd love to see that at 100%, right? Because everybody who comes in through our doors is either eligible for NYC care or insurance, and we set a target of 76%, and we'll drive towards that. Our key diabetes measure, Eric can speak to as well.
I just have a quick question on the uninsured patients. I'm surprised that the number is not higher. I know at Metro Plus, our insured patients went from 500 to 600,000 since the beginning of the COVID surge to the end of December.
Yeah.
And I would think that Health Plus would have experienced the same. I'm just a little surprised. I think more people would have been moving into healthcare insurance.
Yeah, I think what it is, Sally, it's a slightly different denominator of people, right? Metro Plus is they get people automatically moving over. Their enrollment activity as people switch out of or unfortunately lose their employer-based coverage, they then become eligible for some of Metro Plus's products.
Yes.
This is just purely a measure of people who walk through the door and how good a job we do of either capturing the insurance that they have or enrolling them in things. So I think this requires a bit more like affirmative choice from people in a healthcare setting, whereas a lot of that Metro Plus kind of growth and stability is, number one, people shifting into the coverage, and number two, they still no one is being disenrolled in Metro Plus, right? There's usually
That's correct. That's
kind
correct.
of rolling drop off. So that
Right.
is the difference. But you're right. We do hope and expect it goes.
Yeah,
up
I think
quickly.
it's going to go up. Definitely. Okay. Thanks, Matt.
Sure. And then on the diabetes measure, I can channel Eric here and Ted a little bit. This is a very important measure of our kind of global success at helping our diabetic patients control their blood sugar. It has been dropping in recent months and dropped a little bit here. I think this is a clear reflection of the difficulty of not having people able to come in for their appointments as often as possible. So it is a drop. I think we probably expected and feared a larger drop off, but the works our team have done in terms of connecting people through telemedicine, having 90-day prescription refills, doing aggressive follow-up with people to get those refills and stay on their medication has made the drop off less severe than one might fear. And then our last stable measures are one of our big IT, HR, and finance programs, enterprise resource planning. That is still at 80% completion. I think we will remove this measure to move to some of the other IT measures we discussed last time, but wanted to report on it here. And one example of success in that program, we no longer have large paper timesheets around the system. We are now reporting digitally. So we have entered the 20th century, and we are hurtling forward to the 21st. So that is great. Our next set of measures is oh, sorry, Sally, go ahead.
No, go ahead. I'll wait.
Okay. I'm just going to give some of the few COVID measures we discussed last time. We have on here the total number of tests administered, and then the number of those tests that are positive. That total tests administered does not deduplicate people. So individuals like nursing home staff who, are required to be tested once or multiple times a week are in there. The city's recommendation is that people get tested monthly or more frequently if there's an exposure. So good to see that number get up, and Ted and the T2 team's success at driving up those numbers. I think we were at over 100,000 tests a few weeks ago, and still trending upwards. Is a key thing that has made the growth in COVID cases this winter linear rather than exponential, and that's been very, very important to us. And then tracking again our post-acute infection rate. Yes, sir.
I just have a clarifying question. On this, the total number of COVID-19 tests administered is only during that period, or this is cumulative from the beginning that we started testing?
That is during that period, I believe, unless someone from the data team is on the phone and can correct me, but I believe during that period.
So it only represents the number of tests carried out from July 1st to September 30. Okay, thank you.
I believe so. And then I think for our next report, when we get back together and in other conversations, we can update on our success at vaccinations. As of Saturday, we were at 21,000 administered in our system. I think as of today, that number will really start to skyrocket because we were pleased to see the state open up the criteria to Category 1B. So that is a large group of essential workers and anybody over age 75. And I think I was at Lincoln Hospital this morning. Their appointments are booked out for 4 weeks. People are really taking advantage of this, and it's very exciting to see us start to work through that supply, which is very positive. Okay. And so then this is just, oh, sorry, question? Go ahead.
Go ahead, Matt. I'll get maybe you'll get to it. So go ahead.
No, that takes us through really all the trends on the measures. I was just going to show the global dashboard and talk about some of the changes next time. But go ahead, Frida.
Okay. So this is actually really great. I mean, just in terms of what you guys have accomplished after the pause, during the pause, I guess. And the one, because even, you kind of talked about compared to prior period in your slides, but looking at the dashboard, even if we go back to prior year, same period, it's all trending very, very well in most of the metrics. But one question I wanted to understand a little more was the primary care patients, and what do you think is happening there? So first, the period is for the 12 months starting when? Is it July 1 or September? Sorry, I think you say at the bottom here, right? October to September, and then compared what's the prior period comparing?
It would have been the prior. Well, in this case, the prior period is
July to July.
June to June.
Or June to
July
June.
to July. Yes.
June to June. Okay,
Just what we reported
so it's
last
capturing sort of the drop during COVID. Is that what's driving that, do you think, or?
That's what I believe that's what's driving that number. We're sort of switching out a very productive quarter for a new kind of less busy quarter, and so it drops the number down a bit, right? Because we lose that July to September from last year when we were fully open and aggressively growing primary care.
Right.
The July to September period where we were slowly reopening and trying to see our existing patients, get them back connected to care, rather than kind of fully marketing ourselves and opening the doors as aggressively as we might.
Right, and we were doing, because we are actually increasing our primary care.
So let's see, and I'll continue to work on Essex Gardens, the Boston deal.
Sorry, somebody's not on mute. And then, so even though we are expanding our primary care, because of what's happening in COVID, that's why we're seeing this kind of drop. I'm just trying to understand the dynamic. So
yeah, we've had a tricky time with this measure, just to get deeper into the weeds than you may want to go. We have had to harmonize prior to Epic, harmonize multiple systems, ways of counting this. Mm-hmm. But now that we are all on Epic, it is easy to update and track quarter to quarter and year to year.
Okay.
But that tried to do it as a rolling quarterly number rather than just wait till the end of the year and give you a kind of
Right.
report back.
No, I like that this way. And then in terms of the target, do we adjust our target quarter to quarter? I don't recall. Is that sort of, how do you manage the target?
We have tried not to. I think, honestly, this COVID period has made each quarter so different from the prior one that it probably would be wise to adjust some of them quarter to quarter. This one overall, the kind of prior year goal was to stabilize the number. It had been dropping for 10 years. And so to have it grew last full year in our mayor's management report out. And so, I think we haven't set we set that target at 418 as kind of stabilizing the drop off. And then, I think our hope was certainly to grow it, but that target was set obviously before COVID. So we could reassess what's a reasonable target with Dr. Long and his team for where they're headed. But certainly my goal is to not drop off on this any year, right? This is our strategy. This is the core of our growth.
Right.
And the number should certainly be stabilized, if not go up every quarter.
Okay. No, I think that makes sense. I just wasn't sure when, so the adjustment happens. Are we going to talk a little bit about changes? And, last time I think you guys had, we talked about our strategy and talked about sort of some of the changes that you've already made. And it sounds like a few more in terms of the IT area. Was that on the agenda today, Fenny, or?
I think we can discuss it. There has been some discussions about any changes, but Matt, how would you like to proceed? I think, Alicia, we are until 2:00 today. Is that correct?
Yes, we have time.
Okay, Matt.
Great. Sure. So just looking at the dashboard, maybe I can show this reflects some of the new measures we discussed, and then I think in our next quarter we'd like to bring forward a few of the ones we already discussed, and then a couple other would love to get this group's thoughts on. First on here, the new measures that we agreed to add as a group last time are the percent of uninsured patients enrolled in coverage. Right? We showed that one, so that's newly reported on here. The post-acute AR days, so a measure of post-acute billing success, is newly added, as well as the post-acute hospitalization rate, a kind of key quality measure for them. And then we have the COVID measures are newly added here. Next quarter, we were going to add the 2 information technology metrics that Dr. Mendez discussed with the group, and the board felt good about. Those are our data center migration progress and our integration of biomedical devices. So I think the thinking there is to add those in as new measures, and what we would hope to do is to eliminate the standalone IT category and integrate those 2, probably I'd say 1 into the financial sustainability category, the data center migration. It's a kind of key operational, but mostly I'd say financially impactful measure, and then the integration of biomedical devices. Either probably into quality and outcomes, because it's really a reflection of how good a job are we doing expanding the footprint of Epic and having all of our devices tied into one system to keep that quality, clinical quality up. So those would be 2 of the more direct changes next quarter. I would love to get the group's thoughts on those before we talk about, I think, a very substantive and strategic one around racial and social equity.
Thank you, Matt. Maybe I can elaborate a little bit if there is okay, Matt.
Please.
I think, Frida, I think this is a good time to look at all the measures that we have there. The idea it was to really ensure that the dashboard kind of aligns well with our pyramid, which has the pillars and the foundational base of social and racial equity. And so here you see in the dashboard that information technology kind of pop up by itself, and in reality is a support to a particular element of our pillars or all our pillars, but I think it has a particular area in which it has the greatest contribution. So that was one idea, to ensure that the dashboard connects well to the pillars, and so the information technology metrics will still be there, but it will be subsumed and reported as part of the pillars that we have here. So that was one idea. The other is that as we have the foundational kind of guiding principle of racial and social equity, to ensure that we also capture in a dashboard some metrics that shows how we are performing with respect to that. Another one that we talked was that COVID-19 definitely has a special category. It's not subsumed within the pillars because it's an element that is out of the norm, but that we are responding. That the COVID-19 we also will add the vaccination, the same way that we have like the test administration. I think it will be perhaps a good way to measure both the first dose, how many people have gotten the first dose through our system, and also the second dose, because I think there are concerns that there may be a drop off, that some people may go for the first dose, but for whatever reason doesn't do the follow up. And we really have to understand the process that we are going to use to reach out to those individuals to get it, or the risk that they may be exposing themselves by only having one dose and not two doses. So those were some of the thoughts that have been discussed on kind of enhancing the dashboard, but I think your thoughts will be very valuable, the same that Jose and Sally as well.
I just, this may not be the right forum for it, but I
Okay.
think we get the number of people that have been COVID tested, the percentage have tested positive, but we don't really get a sense of what that's been on the hospital, how many people were admitted, how many people are in intensive care. So what's going to give us a sense of the surge, I think, is going a little deeper into those numbers. I'm sure we have them. I don't know if this is the forum to add those, but I think those are the most critical numbers impacting, well, not the most, well, yeah, I think the most critical numbers impacting the system directly.
Sally, that would be.
Yeah,
that
go
would
ahead.
be, go ahead.
I can speak to that. So Sally, absolutely. I think on our intranet page, we even track number of patients successfully treated and discharged with COVID. That's like kind of a positive reinforcement to our staff of what we're fighting for. I think on a quarterly basis, those numbers might not mean as much. We meet every morning at 7:30, and we're looking at this data in real time and making decisions off of it. So I don't know, right, the number of patients 3 months back that were in our ICU with COVID, or right, in our hospitals with COVID would be that meaningful in this forum, but maybe something about patients successfully treated and discharged home, or just total number of patients that, so I think there's summative metrics that might give a picture of just how many patients we treated, but we're hoping that in a couple quarters that this will not be back to zero like it was
right
2019. So.
Eric, is that something? Are those statistics you're talking about on the intranet for every day, or is that updated? No.
No, there's specific dashboards, and each of the dashboards has a different kind of group that have access to it. But I think, right, if there's interest on the board of seeing some of that data, we could definitely have offline discussion about that.
Well, at some point, in whatever forum it is important for us to have a sense of the surge, the magnitude of the surge. Because I mean, I haven't looked at our website, but I really don't have a sense of how things are progressing on that front. So wherever it's reported on a current day basis, at least as of the date that you're speaking, it would be useful to see what that looks like.
And I know in the first surge, Michelle had invited board members to join one of our Tiger Team calls. That's kind of morphed into our incident management team, and we have the daily planning calls at 7:30, and then we have a system report out briefing on Wednesday mornings. So that's something that we could revisit again if there's interest in joining one of these system briefings just to see how things are going, and then to, open to ideas such as the board meetings. Should we give a, are we not covering enough in terms of the president's summary of what the current surge, and if we want to add more there, or are there other forums that you would like to get updates on?
Yeah. Frida, do you have something else to add?
No, on this, I think we've talked about it, but thank you. But I think just on the general dashboard, shifting back to our strategic planning committee dashboard.
Yeah.
I guess a couple of the things that I just wanted to make sure we were capturing. I like the changes that we've already made and the ones, Fenny, that you and Matt have just talked about. But I think, one of the key things that, at least in the financial sustainability pillar, that I probably am more familiar with, is the value-based care progress. And I know we have some metrics here that speak to that. For example, growing our primary care patients and many of our our quality measures, et cetera. But there's a couple of others that I sort of, was sort of, I more had a question about, not knowing what the right measure is. But for example, patient care revenue as a percentage of expenses, is that, I think that's a really important metric to track, but does that help us identify how we're doing on, our progress on value-based care? Like what are the right metrics to help round out that picture? I'm not sure if they are all here or not, and it's really more an open question.
It's a really great question. I think, when we've talked about our success in value-based care, you can break it down in a lot of different ways, but I think I sort of look at it at three key inputs that we built into our financial strategy for the year. The first is, as you pointed out, how are you doing on primary care growth, but not just overall volume of growth? How are you doing on the attribution, right? Capturing that patient and saying, you are not just coming in for a walk-in visit and we never see you again,
right,
but you are an attributed and a core part of our system and our practice. So internally, we definitely track that number, right? Not just our total number of unique patients, but in the financial plan, we track how many people are attributed to us, that we have said, this is your primary care doctor, Dr. Long is your doctor, and you are with them and a part of our system. And that's a different number. It's lower, but it's very significant still. And tracking that growth both as the number of people insured in our key value-based partners has grown, and as we do a better job of when people come in, we say, not just ask them for their insurance card, but say, are you seeing the right doctor today, right? Have you really been a part of our system? And if not, let's change that and make sure that we have that longitudinal relationship. So I think that's one. That's sort of the front door. The second is a measure that is on here, I think, to a pretty meaningful degree, which is the percent of Metro Plus spend at health and hospital. So, how good a job are we doing at keeping that business in our system and saying our job is really to coordinate your care, and we're not doing a good job from a value-based perspective if, we sign you up, you have a primary care doctor here, and then you're, going into the emergency department at Montefiore, 10 times a month. That means we're not being successful on behalf of you at helping your journey on value-based payments. So those are two key ones. And then I'd say the other one that we track is it's a little bit wonky for a board presentation, but I'm open to it because I track it very closely. But getting people enrolled in the right insurance product for them, right? There are specialized value-based products that we are a part of, special products for people
HIV.
with HIV, special products for people in what's called the Health and Recovery Plan, which is targeted people with multiple chronic diseases, behavioral health, substance abuse issues. These are the key ways or some of the key ways that the state has said we put a premium on people who are committing to taking care of these high need patients, and that we and Metro Plus and Health First and others, are committing to working on together. So we track our enrollment in those and are working, I'd say, very aggressively on that. So those are all three tracked in our financial plan, but it's sort of that stepwise fashion. Are you getting people in the right way to their doctor? Are you getting them in the right plan? And then are you doing a good job, managing their overall care?
The special care.
So at least from the financial perspective, those are the key measures we use of value-based care and our success.
So Matt, would you, do you think that what we have on our dashboard now is a good measure or indicator of our success? Because you clearly are seeing more indicators, right, than we see here. But maybe what we have here is enough. And I don't know well enough to know, right? We don't need to load the dashboard with a whole lot of statistics that just for the sake of loading it. But I would like to be able to capture the progress adequately.
Sure.
Matt, following
Sir.
up Frida's comment, maybe it would be good for you, Frida, to meet and try to look at those metrics that are in the dashboard that relates to the financial sustainability, since Frida has such a wealth of knowledge. Do you think that would be possible?
Sure, absolutely. Would love to do that. And I think it's an excellent question, Frida. And I think we have things on here that give us a window into our success. But I think it's always worth looking at and saying, if you had to pick one, right, or you had to pick two that really give you that snapshot, we might add, we might subtract, we might change. So I'm happy to. I think it'd be great to sit down and talk through that offline with you and potentially with John. I know he's interested.
Yeah.
And then we can maybe bring it back to this group and see if there's a recommended adjustment.
Great.
Matt,
Thank you.
looking forward,
Thank you, Fanny.
looking at the key metrics, positive and negative. This is just a sneak preview maybe, but is it your sense that over the second quarter, the numbers have continued to increase?
I think over the second quarter, let's see, a number of them will, right? I think we certainly opened up a significant amount more, saw the volumes, both in primary care and specialty care, just the general activity in our facilities increase a good amount in September, October, beginning of November. So I think the financial measures and the access measures would look better in those months. Quality and outcomes, I hope we see those improved. Eric might have a better sense of how the fall has progressed there. But I think, by the time we get into November and December, we did start to shift some operations and start to see some of the changes again from a surge period. Not to anything like the extent in the spring, but I did feel good about the fall period when I was having, as we had these monthly budget meetings with our CFOs and kind of tracked and CEOs tracked the progress there. But Eric, clinically, any sense of how these different measures were tracking through the fall?
Yeah, no, I think we saw things start to recover a bit. We were bringing patients back into clinic in person, doing more video visits rather than only phone visits. We saw the ED volume start to tick up again, and that was also like while cases were still low, now it's up, mostly because of new COVID cases. So I think we'll see some of the numbers that dipped rebound in that quarter. But as Matt mentioned, we're right in the middle of the second wave, and we're hoping that it peaks by the end of January. So making some of those hard decisions again of throttling back operating rooms and in-person clinics to use those resources to treat the critically ill from COVID in our hospitals. But that might show up in third quarter since we're now in January.
What's straining our resources more than maybe it's the same? The COVID, dealing with the COVID surge, or the vaccination implementation?
It's mostly the COVID surge, I would say. But the vaccinations are, that we're using in our Gotham and acute hospital sites are pulling from that same resource, right? Whether it's internal staff that we're redeploying or agency that's coming in, two priorities that we're fighting over the same resources.
Right.
And I would say this wave, the biggest difference is that we're still seeing almost the same level of non-COVID volume as we did pre-pandemic or pre the second wave, which is very different from the first wave, where 2/3 of our volumes disappeared almost overnight. It was a matter of weeks that 66% were gone, and so that we would focus solely on COVID. This time, it's taking
Right.
care of our normal patients plus COVID patients. That is, right. If 66%
Yes.
of our patients went away, this wave
Right.
would be easy compared to the spring, but it's feeling just as hard or almost as hard just because, and we think it's a good thing, right? That it's good that our patients are still seeking care that they need and that we can safely protect them from getting COVID in our facilities. But that's, I'd say, the biggest difference at the 30,000-foot view is how do you treat a COVID surge while maintaining the same services and volume of non-COVID.
Right. Right. Thank you.
Thank
I'd
you,
say
Eric.
the only thing I might, if I could, Mr. Chair, I'm sorry, the only thing I
Yeah.
might add to what Eric said is, one difference that I see that's very significant is just the knowledge, right? The knowledge gap. We forget how much in the spring people were learning about this virus as we went, but that not only impacts our ability to treat non-COVID patients at the same time, the acuity, the survival rate, the length of stay, all of these measures are much improved from the spring. So that's very important and helpful for our staff and everybody working on this. It's certainly tough to see the volumes go up and the cases rise, but it's certainly a different type of acuity that we're seeing so far. So that's very, very positive.
Thank you, Matt. I wanted to ask Jose if you have any question, Jose.
Just a quick comment. As I was thinking about like how the data gets aggregated from different facilities, it may be worth at some point I was thinking about like the emergency management dashboards that we already use that are done in Tableau that add up data like that. Maybe there are a few of these measures that lend themselves to something like that. Maybe they're based on priorities from the board or your priorities or all together. But anyway, something to think about so that the measures have. It's hard for me to tell exactly how much ownership there is at the facility level on all these measures, and I guess that's what I wanted to bring up.
I think it's a great point. I mean, I can speak to the ownership at the financial level and kind of how we think about that and work through it. Eric, then perhaps on the clinical and certainly on the data side. We, on all these different financial measures, we certainly track them and review them each month in the budget meetings attended by facility CEOs and their whole leadership teams. And if we don't track these specific measures, I'd say we track the key kind of more detailed inputs that add up to these. So they are built into budget targets that all the facilities have, tied to our financial plan. So that is certainly the way we do it there, and then review at the system leadership level with Dr. Katz on a monthly or bi-monthly basis as well. So that's one of the ways we try to build it into facility ownership and alignment around these measures. The only difference, as I said, would be when we have a slightly more detailed measure or additional measures for the facilities than what we present to the board. But and Eric and his team are building out dashboards at a rapid pace. It has slowed a little bit to focus on some COVID dashboards, but they are certainly out there and in production on many of these measures. And Eric, I think through the QAPI process and other avenues, you try to have facility alignment and buy-in on these as well, right?
Yes, thanks, Matt. So similarly, I think, right, there are different forums and different venues. For example, the MyChart activations, if you look at the intranet home, it shows by facility, our DNTCs in our acute hospitals, and they kind of see how they rank against the rest of the system, as well as the overall system goal, which, you know, I know we reported 36% here, but it's much higher even today than when we finished this quarter. And that's emailed out. There are MyChart steering committee and then councils that include the facilities in that. And so I think all the CEOs get this on a regular basis and are sort of competing with each other, just like with vaccinations on who's signing up the most patients for MyChart. In terms of the quality and outcomes, a lot of them are in the QAPI books, and that's covered every quarter. At the very least, the ambulatory ones are covered in ACLC. They're in the prioritized 15 metrics that the ACLC came down on. And then with the percent level without being seen is not only in QAPI, but discussed in the ED Council. So I would say it's in multiple forums. The Care Experience Council covers the Press-Ganey scores. While I'm at Elmhurst here on a almost weekly basis, I get updated Press-Ganey scores in my inbox. And so I would say that all of these are touching the inbox and, you know, being verbally discussed with our leadership, our CEOs at the facilities on a regular basis. And they do feel ownership knowing that it is on the system dashboard and are working hard on them.
Yeah, thanks.
I just have
Thank you.
I just
Jose,
have
you
one. It's okay. Go ahead, Fanny.
Sorry, Sally, I just want to make sure that Jose has all his questions answered.
I had
Jose?
one quick final one, and yeah, thank you, Eric, for the details on that. The other one is just more of a comment on my chart. You know, as you think about, I suppose activation will hit some sort of saturation point, right? That you would expect 50%, 60%, I don't know, some number around there. So once you hit that, thinking about measures on, thinking about what is the best way to optimize its use, be worth it. The measures that come to mind are connected to communicating with patients, how well are physicians using it, and nurses in a way that allows for better communication. Something around that area is the one that comes to mind. I'm sure you can think of others. Just wanted to make that comment. Thanks.
And Jose, we do cover those in the steering committee. It's the number of patients that are activated, the number of patients that have logged in since activation, you know, within the past 12 months. And then there's other engagement ones, like how many times have they messaged their primary care physician through MyChart. So we should see this as the implementation phase. We want to get our activation up quickly. But in the sustainment toward optimization phase, we want to make sure that it is meeting the needs of our patients, right? It's actually useful, not just that they signed up to get one lab result, a COVID test result or something like that.
Right. Eric, just on clarifying that MyChart activation statistic, that's 36% of all our of who?
It's 36% of all our patients.
All our patients, okay.
Jose?
But with a caveat that we're giving COVID results through our T2 and H&H testing site. And
So that means if you had someone just come for a test and they activated MyChart but never saw an H&H provider again, that counts?
Yeah.
Oh, okay.
They're boosting both the denominator and the numerator, but our goal is to convert as many of those into long-term H&H patients.
Well, are you tracking that at all? That's sort of an interesting opportunity.
That one I have not seen data on, but I know we've discussed, you know, strategies on how to engage them.
Right. That would be
overall kind of feedback that we've gotten is very positive on the testing as well as the vaccination now.
right.
And so we should ride that kind of good impression into why don't you come and get your care? And I've heard anecdotes of people's friends who they sent to T2 testing sites who now have asked to be enrolled in the primary care physician H&H.
Oh, that's
So
great.
employees and friends of employees, so forth. So we definitely an opportunity and something that we want to ride the enthusiasm.
That might be something to just not necessarily for our dashboard, but just to start tracking, because I think it's an opportunity. You know, we've been given this task of T2. We're doing a good job at it, great job at it, and that maybe we can show the conversion of how that's helped. That would be interesting.
Yeah.
Jose, do you have any other questions?
No, thank you so much.
Sally, sorry that I interrupted you.
That's okay. No, it's not a problem. I'm kind of still stuck on this question of monitoring the surge because of the financial impact it has on H&H, particularly in managing it while we're also handling the vaccination process. So I wonder if it's possible for the board to get a weekly or bi-weekly trend line that shows the number of patients that have been admitted to H&H with COVID. Or you know, you don't need to go to those that actually have ended up being intubated or died, but just the number of patients that have actually been admitted to H&H that with COVID.
Sally, I think this is something that also will be good. Maybe Matt and Eric maybe can have an offline discussion with you to see what will be the best measure to capture that in the COVID-19
Sure.
category. Particularly,
Okay.
these are metrics that it has been used almost throughout the whole United States is ICU capacity. And some states are using that percentage of how much left capacity. Like if you are at 80% or 90%, you trigger certain measures. So maybe we can have an average of the daily ICU capacity throughout the quarter as a measure. I don't know if that would be meaningful or significant, but I think maybe if you, Matt and Eric is okay, maybe you can have a conversation and capture and see what would be best way to capture that. Is that okay?
Okay.
Matt?
Sounds good.
Yeah.
I think there's a lot of good ways we can cut for you how the surge is progressing and how our facilities are stepping up in amazing ways. So happy to show that. I'm sure Mitch will talk about it in the president's report,
Operating
but
report,
giving more details in an ongoing way seems totally reasonable and happy to do that. I think you know I can give you the gestalt of it, right? The numbers are certainly rising coming out of the holidays. It's been a linear rise throughout December. And so no major spikes, which has been really important. It's also been, I'd say, geographically distributed in a way that the spring wasn't, right? The spring hit very, very hard, particularly in Queens and then
the Bronx.
You know, and the Bronx, and in other places, but those primarily. This time it's been spread more around our facilities. Coney Island has seen a lot of admissions, but has been very strong and very stable. And we've done a significant amount of level loading. In the whole surge last time, we did about 850 transfers. So far in this surge, we've already done over 330. So we stay very much ahead of that, move patients early when they're stable, you know, keep people really ahead of strain. But the cases are certainly growing, and you know, people are looking at things like their elective surgery volumes and bringing in more staff from the outside, which has been a challenge given the national strain, but people are holding up very, very well, and I think you know we are eager to vaccinate as many people as possible, as quickly as possible, to you know continue to stay ahead of this case growth.
Okay, thank you, Matt. That was very helpful.
Sure.
Thank you. And so I don't know if there is a lot more information to share, but I just want to kind of wrap up in the dashboard. I think you already, both Matt and Eric, have some comments from Jose, Frida, as well as Sally on maybe some of the measures or metrics that may be able to be looked at for consideration to be added in the financial sustainability. And you are going to have like an offline with Frida and about that, and maybe with the COVID-19 with Sally. I think that also will be good. I know that we also discussed that some of the reporting frequency has annually, like for example, the unique primary care patients seen in the last 12 months, as well as the acute care overall safety grade. And you were going to look and see if you can have ways to present that information in a quarterly fashion so that at least we can see how that progress. The other comment that I may suggest is that as we are organizing the dashboard, since we have the pillars, I don't know if the pillars have any prioritization among them. If they don't, maybe we can use the alphabetical order as we list them here, access to care, care experience, culture and safety, financial, then quality, and COVID at the bottom of the system in special category. I don't know if that will be a way so that doesn't have any implication of priority, but if you have a priority, just put it in the list of priority. That may be something. And then, as you say, you will look at how to embed the information technology metrics within the pillars and add the social and racial equity metrics to the dashboard. Did I miss something? I just wanted to wrap up. Jose, did I miss something from what you asked that should have been incorporated?
No, that's fine. Thanks.
No? Frida?
No, but Matt, just since I have you here, could I ask a question on how the Hunter contract is? It's because we brought that to the finance committee, but I know this is hijacking strategic for a minute. But
That's okay.
Yeah, we can bring it back at any time. They're very busy for us doing these transfers, and I think we have the flexibility in the existing not to exceed to not bring it urgently. So I've really just been watching our transfer teams time in terms of when they can come and help present, but we could bring that forward at any time that the board is ready.
okay, so you don't have a deadline that needs to be
Not urgently. I think it's a matter of cleaning it up and then getting from them the MWBE commitment that we hope for from them and expect from them. And so I'm waiting for some material back from them, and then how much we want to negotiate and push on those key elements while they're in the midst of a surge effort for us, I think is part of my thinking.
okay.
But I don't feel any urgent time pressure just from a contractual perspective and a financial perspective to make the change. We want to do it right, with the feedback the board gave, and so I'd rather take a little bit of time, get through the surge, do it right, and then bring it back if that's agreeable to the board members.
That makes sense. Thank you.
I was at one of our hospitals today, and the CEO repeated to me something I've often felt, that there are two things that let us get through the surge besides our amazing staff and everybody's teamwork: having a system-wide Epic and having a system-wide transportation vendor. Just the ability to knit our hospitals together and have them support each other has been really, really critical. So thank you for the question. And Benny, just on your point about prioritization of the pillars, pillars they're like our children. We love them all equally. So there's no. We had them organized so that I could do the first two and then Eric could speak to the rest, but we can reorganize as needed. But thank you all for your support and for another great quarter at Health and Hospitals.
Well,
Yeah.
thank you.
Thank you, Matt and Eric.
Yes, thank you.
I don't know if there is, do you have any other material to present, both Eric or Matt, or this is it?
Not for me today, sir. Eric, anything you want to close with?
No, I think the priorities are to get the vaccine out there so we can get back to our new normal. And so, we're playing a bigger and bigger part in health and hospitals in the vaccine rollout. So look forward to reporting on that success in the quarter.
I just want to thank you, both of you, as well as your colleagues and the whole team of Health and Hospital, because, you always hear that in the time of crisis, you wanted those steady hands that understand that we are in a crisis, but are guiding us very securely, intentionally to where we should be. And we have seen this throughout this, even though you're dealing with a lot of different challenges and reacting, changing your procedures on how to respond to the pandemic and adapting. You have kept a very steady hand, ensuring that nothing gets like by the sideways, and kind of looking at the protocols as well as our normal day-to-day business, ensuring that we have a very robust organizational and financial structure, and we see it. And I would like to thank you for keeping that steady hand and for all your contributions. And like I think I share this feeling with my fellow board members. We have been extremely impressed. You are an amazing group of leaders that we are so thankful that you are in Health and Hospital and helping lead us through this challenging crisis. So thank you so much, both of you and your teams. And I would like, if there is no any new business or any old business, being no further discussion, I would like to adjourn this meeting and thank our fellow board members for your participation and for your energy after the holidays. And we are all, very kind of enthusiastic on being part of this organization and being part of the great work that you are all doing. Thank you so much and have a
Thank you.
wonderful day.
Bye-bye.
Thank you,
Bye.
Fanny.
Thank you.
Bye.
Bye.